Today's topic is the effect of diet and exercise on metabolic syndrome hormones. It was announced that we were going to do the effect of diet and exercise on metabolic hormones, which is really, since all hormones control metabolism, it's like saying effect of diet and exercise on hormonal hormones. I didn't think that was that clever. So in any case, signaling, what do hormones do with the signaling? Is it healthy or not? That's the title. What is a hormone? Okay. Hormones are simply signaling proteins. The body works by sending signals, and those signals instigate pathways. That's the chemistry. That's really metabolism. All right. So the signals that come from hormones, these are powerful signals, signalers, global signalers. They affect responses. They make responses happen in the whole body. They're the master signaling agents. And people ask me, what about enzymes? What's the story on enzymes? Enzymes really affect how hormones work. So to clarify that a little bit, hormones dictate a certain chemistry, and enzymes really affect how slow or how fast or how significant these things are. Okay, these processes become. How do we create hormones? How do we make hormones generated or created by endocrine glands? Certain glands produce these chemical signals. The glands produce them, and then that chemistry, those particulates head through the body, through the bloodstream to certain target areas. Okay, so each target area, which means a group of cells, pretty much have receptors to different hormones. We know, for example, about insulin and insulin receptors on the muscles and on the liver, but all hormones work that way. They have receptors to get their chemistry and therefore their signals into the cell through the cell membrane. So hormones control growth, repair, reproduction, digestion, and they regulate homeostasis. So hormones are really the yin and the yang of basically our body chemistry. All right, so they're very important. Another important element is that hormones are structured. A lot of the steroid hormones are structured from a basis of cholesterol. Cholesterol is an essential structure. Steroidal hormones, estrogen, testosterone, other estrogens like estradiol, cortisol, and more are basically physically constructed, architecturally, with cholesterol. So important energy hormones. These are the hormones I think that really are affecting us, we that are concerned about metabolic health, weight loss, diabetes, obesity, these kinds of things. These are kind of the important ones. We all know about insulin. But insulin's job is storage. I call it a hibernation hormone. It's telling the cells that store energy not to use it. Now, in an anthropological sense, the development of the species, that was very important. Now I got to go back because somehow I made this happen. Sorry, folks. Okay, so insulin allowed us to store energy when we had a shortage of it. And since we didn't have 7-Elevens, stores like that as it developed as a species, it was very important to store energy, to kind of hoard it. Now, on the other side of the seesaw is glucagon, and its job is usage or activity. What that means is when we had to be active, when we had to hunt, when we had to flee, when there was some kind of an emergency physically, glucagon turns on, and it wants us to use energy and allows us to use energy to preserve the species. Insulin comes from the beta cells in the pancreas, glucagon from the alpha cells in the pancreas. They are kind of living together, and they're the yin and the yang. They keep the balance, okay, of this stuff that we want to have happen metabolically. So they're major hormones for energy storage, energy release, things of that nature. Human growth hormone. I like talking about this because I don't think this is a very well understood hormone. It is a master hormone. If there's one hormone that has some possibility of reversing or overcoming the power of insulin, and probably nothing really does, it's HGH. So what is HGH? It's a hormone, basically a hormone of youth. It's it is the master growth hormone. There's a huge decrease with age in the literature. It shows that, but I think more than with age, I think it's with disuse. and the lack of stimulation of to manifest the benefits of growth hormone. So here's what happens. People come to me and say, should we take HGH? Will it make us, stronger, healthy, more vital, improve our health? And I give this example. You take a 25-year-old medical or law student in school, and their levels of HGH secretion are very high, okay? They don't do anything. They study, they sit, maybe they drink a little bit, party a little bit. All right. They have very poor muscle structure. They're in very poor physical condition, yet they have a huge amount of HGH secreted into their body. So what's the problem? The problem is HGH, human growth hormone, increases muscle mass, but it must include high-intensity exercise. It needs something so that it can manifest its potential, make the stuff happen that it's capable of. What else does HGH do? It promotes visceral fat reduction, cell regeneration, many youthful characteristics. That's why it's supposed to be such a powerful, and it is a very powerful hormone. Okay, so HGH, not to be feared, that there are cancer fears and all these things. The real literature, the real people, and I work with some of the endocrinologists on the Olympic boards that screen for HGH, they say this stuff is way overblown, that there's a benefit to it. Not that I'm telling everybody to go out and take HGH, but we can do some behaviors and eating and an exercise that can increase our HGH level so it doesn't decline in the normal course of events like it does in most people. Okay, so it's not normal aging. Testosterone. Okay, obviously everybody knows testosterone is a male-dominant hormone, but women produce and need it. And certainly in recent times, I know that I've had a lot of gal patients that are low in testosterone, and if we correct that, a lot of good things happen metabolically. Thyroid level increases, muscle building, osteoporosis, things like that. Protein synthesis, that's one of the things that testosterone drives. It strengthens bones and collagen as well as muscle, and it downregulates stress hormones. Now, this is kind of an interesting factoid that I'm going to go over with you. 80% of women, of the people diagnosed with depression and anxiety are women. Okay, cortisol is the stress hormone, and we'll see that in a slide or two. Now, what does that mean? That means that women are more sensitive to cortisol and the stress that ensues, okay, than men are, because testosterone inhibits the sensitivity to cortisol. So men theoretically, and actually in practice, respond less significantly to the stress hormone cortisol. Now think about that in the anthropological sense. Men, if they were always aware of stress around them, would not express the bravado it takes to hunt and to fight. And by the same token, women have to be sensitive to cortisol because they had to be aware of danger and in protecting their children. Okay, so there's a reason for this stuff. So there is a reason why testosterone is important for women. So testosterone reduces the stress response, and I just explained the differences between men and women. Okay, estrogen. Okay, we all know that estrogen is predominantly a female hormone, but men produce some. What is estrogen? What's its power? It's necessary for reproduction, for normal libido. We know as estrogen decreases, libido decreases. It also, estrogen protects against vascular inflammation and osteoporosis. That's why women have much less of an incidence of inflammatory, except for autoimmune inflammatory kind of responses, but vascular inflammatory diseases and things like that before menopause than men do. Again, it upregulates responses, stress responses, and controls cravings and resting metabolic rate. So we also know that when women go through menopause, they have more significant cravings. Their resting metabolic rate slows down. There's where the fat increase happens. So there are reasons for this, and the reasons are the hormonal milieu or the hormonal situation. And when that changes, then your metabolism changes, your chemistry changes. Cortisol is a master stress hormone. We talked about that a little bit in the testosterone slide. The upside of cortisol, it triggers immune responses and tissue regeneration. Again, in the development of the species, we had this hormone that basically allowed us to drive recovery, to heal wounds. Okay, so there's an upside to cortisol. There's a benefit for it, and I guess that makes sense that it's not just all negative. The downside of cortisol in modern society is when we have this chronic stress, not emergency stress, not high levels, but this constant chronicity of stress, the adrenal glands become compromised and they become exhausted. Therefore, anxiety and depression. Interestingly enough, the highest levels of cortisol in the blood are found between 8 and 10 a.m. Excuse me, part of the dawn effect, people know that check their blood sugar, that when they wake up, they have this high level of blood sugar, and that's because of this dawn effect. I guess when you're waking up, again, in prehistoric or in Paleolithic times, between 8 and 10 a.m., you had to be ready to go in case there was some predators running around, or you had to go to another place for shelter. So, but cortisol is measured almost predominantly between 8 and 10 in the morning. They want you to measure this thing. Incretin hormones. This is something I'm very recently studying. What are incretin hormones? They are hormones that are released in the GI tract, in the gut. They're released after eating, and they modulate insulin response. There's some decent literature that shows that this can have an effect on insulin response, on energy storage. There are two sets of incretin hormones, one from the small intestine, one from the large intestine. This GIP, gastric inhibitory polypeptide, sensitizes the beta cells in the pancreas to more efficiently secrete insulin. In other words, as we eat whatever it is that needs insulin to assist it into cell membranes, mostly carbohydrate, a little bit of protein, this gastratory inhibitory hormone actually increases the sensitivity to insulin, so we don't require such a large amount. And we all know that if we can keep insulin response down, it helps in our energy balance, things like that. GIP works with CCT, cholecystinin kinase, which lowers glucose production. You don't need as much glucose because of the sensitivity that this produces in the beta cells. There's a GLP-1 glucagon-like peptide, which inhibits glucagon function and induces satiety. That comes from the lower GI tract. So this is kind of a new hormonal kind of discipline, but I think it's worth more study, and I'm going to personally study it more so I can give you more information on that deal. Leptin. We all know about leptin, or I think we've heard about this if we're into this field at all. Okay, what is it? It's a satiety hormone. It tells us when to stop eating, basically, or that we can stop eating. Sometimes it doesn't speak that loudly to some people as others. It's very tightly correlated to insulin response. Diabetics and overweight people become leptin resistant as well as insulin resistant. Unusual hormones to measure. Okay, so when we talk about all these different hormones and their advantages and what they do and what they control, why don't most doctors test for a lot of these things? So I would advise, if you have a good rapport with your doctor, you can kind of tell them what we're talking about, or if they can watch this presentation. And there are real good reasons why we want to test some of these things. Fasting insulin levels, I think we're getting pretty much an agreement that this is a very good measurement to have. Fasting insulin levels will start to rise, okay, and get out of hand a little bit, maybe up to 10 years before the manifestation of diabetes in the form of high sugar levels. So understand, before your sugar levels get to what's considered a diabetic range, fasting insulin levels will indicate that, and it's a forewarner of this stuff that's about to come if you don't change behaviors or somehow change your metabolism. Leptin is another one to change, and the reason I asked to do that is because sometimes it will tell me that a patient is having trouble, which we know from their blood sugar and things like that, and insulin levels, but we know that they're going to have trouble controlling eating because they are inured, they don't respond to high leptin levels, they become leptin resistant. So we're going to have to maybe go into some more behavioral things and ways that they can maybe stop this physiological craving of food behaviorally. So that's why I would suggest that. Fasting glucagon is something I'm looking into, and I think if we understand the importance of fasting insulin levels, why wouldn't it be logical that fasting glucagon, the opposite, the yin and the yang, the other side of the seesaw, would be interesting to measure? And I'm not exactly sure what we're looking for, except I think maybe there's a relationship or a ratio that we might ascertain between insulin levels and glucagon levels. So that might be something. I haven't done it myself. I'm going to do it when I get back to Scottsdale in about 10 days. IGF-1, what is that? IGF-1 is the way that we measure the usage of growth hormone, how growth hormone has been metabolized. So you don't measure HGH usually singularly, you measure IGF-1. That's a very interesting measurement, although it has a wide range of what they call normal. I would think we're going to be able to narrow that down and say maybe if we can increase that, and you can increase that through behavior, through diet and exercise. I would really be interested in see the effect of diet and high-intensity exercise on IGF-1. I've done a little of that. It looks like we do get a little bit of a bang out of that. But that's an interesting hormone that most doctors won't do because they're afraid you're going to get black market growth hormone and put on 35 pounds of muscle in a week or some ridiculous thing. Okay, testosterone. Again, more and more I'm having women, in fact, all of my women, test for testosterone or get tested for testosterone. I would like to tell them that I have seen really good improvement in metabolic rate if they bring the testosterone up to a normal. I have some women that are somehow told to come back and the doctor said they were below zero or at zero. It's not normal, it's not healthy. And so a little testosterone therapy for women is actually, and for bone density, I've seen really good improvement with that, along with, manifestations of high intensity exercise, controlled carb eating, things like that. So this is where we want to go with these extra tests, these unusual hormones. What to do? All right, so we know all about these hormones. We understand what their powers are and the pathways that they instigate. So what do we do? Okay, through diet and exercise. Well, we control carbs. We eat a higher fat, protein kind of a diet. We control carbs. That in most cases is what we want to do, because that enhances and upregulates glucagon, HGH, testosterone, leptin. Okay, these are the hormones that we want to have working at a vibrant, healthy level. And so low carb eating instigates that. And low carb eating downregulates, inhibits, reduces cortisol, insulin responses. High carb eating demands insulin response, of course, because carbohydrates need insulin to get through the cell membranes, okay, to get through. So, and also high carb eating produces poorer digestive hormone support, testosterone, and HGH production. Controlled carb eating, higher fat, enhances, upregulates glucagon, HGH, testosterone, leptin, which are good hormones for metabolic health and activity. It downregulates cortisol, insulin, those kind of hormones that we would like to downregulate. But high carb eating demands higher insulin secretion, poorer digestive hormones support testosterone and HGH secretion, and those are the ones that we want to enhance to maintain a kind of a youthful, healthy metabolic milieu. Lean tissue and bone and muscle building responses, okay, are diminished if we have lower levels of the hormones that affect it. So controlled carbohydrate eating, good. Actually, high carbohydrate eating, bad. I mean, kind of a simple takeaway. What to do as far as exercise? So we know low carb eating, controlled carb eating for diet, low carb eating combined with exercise activity. High intensity exercise promotes, upregulates HGH, testosterone, glucagon, gastric hormone effectiveness, estrogen balance, leptin sensitivity. These are all very good hormonal responses that we want to induce behaviorally, and high intensity exercise does that very powerfully. The muscle system is a very powerful signaler and hormone driver. High intensity exercise is best taken intermittently. In other words, what's our dosage? Not every day. And there are reasons for that as we developed in the species. As a species, high intensity exercise, emergency, life or death muscle action would have killed us if we had to do it every day. We could never have overcome the stress and the exhaustion. So we have a twice a week exercise protocol called SMART, which we think hopefully is the opposite of stupid. And so twice a week, exercise taken twice a week, high intensity every 3 days, anything like that. High intensity exercise is applied with local and global consideration. Remember, I told you in the beginning that hormones are global. They affect most cells in the body, but we can instigate that secretion, that upregulation of those good hormones locally, which means by working specific muscles. And we do work specific muscles to produce global responses in the SMART or the high intensity system. So hormones are global signalers, okay, meaning they work in your whole body, but they can be instigated locally by exercise, the right kind of exercise. Controlling hormones effectively. Okay, how do we do this thing? How do we make our hormones work to our advantage? Give us the biggest bang for their buck. Again, it's the same old story, but from a different angle. Controlling metabolic signals and pathways. That's what controlling these hormones do through diet and exercise. Diet controls hormones. Exercise controls hormones. The takeaway, control carbs and manipulate the muscle system properly, and we can direct those hormones, those powerful signalers, to our advantage. That's about it for now, and we'll take some questions, I believe.
All right. Dr. Ben, can you give examples of healthy fasting insulin and maybe healthy readings of the other hormones you talked about?
Yeah, I should have brought that with me. Brian, correct me if I'm wrong. I think we want fasting insulin to be like under 6, something like that. Is that accurate, or just give me? I should know the numbers. I used to know the numbers like last week. Anyway, Brian.
Ideally, we like it less than. Am I unmuted?
Yes.
Yeah.
Okay. So ideally, we like it less than 5, and it really depends on the whole clinical situation, right? If your sugars are really high, we want your insulin to be higher to try to get rid of that, right? So hopefully, as we make someone more insulin sensitive, or we make ourselves more insulin sensitive, the insulin naturally comes down, and the sugars come down, and the 3-month sugar average come down. So, in my discussions with Jason Fung, who I think is one of the experts on this, less than 5 is ideal for an insulin level, given normal sugars.
Okay, hopefully that helps. So obviously anything 6 or above, that's maybe what I was talking about, start to be a little bit concerned, or at least it's indicating that there's a lot of insulin circulating, which means hormonally, go back to the talk, it means hormonally there's a lot of hibernation signaling, which means not utilizing energy, which we don't want. Kristen or Brian, I don't know the glucagon levels, to be honest with you. I'm just getting into trying to get some idea what we're looking for, and I'll have to look into the literature, honestly, to see if there's something that gives us an indication. Are you guys familiar with any of that? I'm not myself right now.
So I have to admit, I don't often check glucagon levels. I'm a big advocate for checking insulin levels, but glucagon normal levels are usually between like 50 to 100. I don't know. I think anything less than 70 could indicate some hypoglycemia, but in the context of a low carbohydrate diet, the guidelines for what's normal isn't quite clear. So normal levels are based on the standard population, and when you have a population that's 88% metabolically unhealthy, what's normal isn't necessarily optimal.
Yeah, my question is more intellectual. Like, will we see some kind of a prime or ideal ratio or better ratio? And I don't know that because obviously we don't have that much data on glucagon because nobody measures it. But I have a sense that there's going to be some kind of a correlation ratio that might be beneficial. At some point, we could produce that data enough that maybe we can make that suggestion. Okay, that's just a thought.
Some of the scientists are looking at that. Dave Feldman, I know, is looking at that. I've had my glucagon checked. Glucagon, for people to understand, is it's the opposite of insulin. It's really glucagon's job is to keep the sugar from going too low. Insulin to keep it from going too high, generally. So, one of the interesting things is once you're diabetic once you get when you lose that insulin effect, this is why we're focusing on metabolic disease. If you're spiking your insulin higher and higher and higher, getting your insulin at 50, and all of a sudden your body can't keep up, sugars go high, it's toxic to the cells that make insulin. When your insulin drops to 0, glucagon says, well, insulin's not there anymore, there must not be sugar, even though your sugar's already 300. But what happens is the glucagon starts kicking a bunch of sugar out of the storage, out of our fat storage. That's why when people first get diagnosed with diabetes, they lose a ton of weight because you've taken the brakes off the system. Insulin is gone to stop glucagon. So when we inject insulin into people, it shuts off that glucagon effect, right? So it's not just the effect of insulin, it's the effect of these hormones looking at each other. So Rob Simon says, our body was never meant, the human body was never meant to run on with insulin being the determiner of sugar levels. It was supposed to be glucagon always. So you're always fighting the lower end of sugars rather than the high end, if that makes sense.
Yeah, I don't think I think insulin would be, and I think still is, the predominant hormone, because you would think, and again, theoretically, that the body would be most inclined to try to survive on the energy that it has, as opposed to using too much energy with a glucagon. So I'm not so sure that I've heard Bob say that, and I respect his opinion, but I'm not sure I totally agree.
You have to look at the history of man. We never ran with an energy oversupply like we do now. That's why insulin is bringing the sugars back down. What glucagon does is, in the morning when we have this non-effect, it's kicking that storage form of sugar into a usable form. It's not useful to you stored in your liver or your fat. So that's the point, is we should be running on those stores instead of eating 6 times a day like we've been told. If you're eating twice a day, what are you running on? Glucagon. For the rest of the time, it's kicking out sugar to keep your sugars normal. That's what I'm talking about.
I understand. I understand the mechanism, but as far as the primal developmental importance, I think insulin will be the master. You would much rather not starve to death than, I think fatigue, if you're using too much energy, you would collapse. Anyway, this is now too deep in the weeds. But okay, next question.
Can someone comment on glucose sparing phenomenon? When the fasting glucose is higher while fasting and insulin is low.
So this is another example of what Brian just referred to about your liver dumping out its glycogen stores. When you have excess glucose from carbohydrates that you've consumed in your diet, it's going to be stored in places, usually your muscles and your liver. And then when it's stimulated by glucagon, your liver is going to be able to produce glucose and get it out into your bloodstream and supply energy to the cells that need it, in addition to ketones you're probably producing while you're fasting. So you can fast for 3, 5, 10 days, and your glucose levels, they might trend down, but they will definitely stay within normal levels without producing a severe hypoglycemic response. Does that answer the question?
Yeah, as long as
yes, I think
as long as you're fat adapted, right? This is why we work so hard at getting people fat adapted. I 100% agree with Kristen. But some people, if you come off a high carb diet, if Sunday you eat chips and pizza and whatever, Monday you try to fast, it's going to be very difficult because your body has a really high insulin level. And when insulin's really high, it blocks you from getting to your fat stores or to break down that liver glycogen. So after a few days, that's why a lot of people come to us and don't want to fast. And then once they get fat adapted, they go, I didn't eat yesterday. They don't care. It's not a big deal because they're running on their fat stores. But it's hard to do that when you have a really high insulin, because what I maybe didn't explain as well, Ben, as I wanted to, is if your insulin's really high, if your insulin's 40, good luck. You're not going to be able to fast. It ain't going to happen. You're going to be dying. You have to eat all the time. You can't, you need an energy source. So with high insulin wants to store that energy. If you're storing all your energy, you're not going to store energy and break down energy at the same time. You have to pick one or the other. So that's the point I'm making is if your insulin's really high, it's hard to get your fat stores, but after getting fat adapted, people do better. They get more adept at giving up energy to use from the storage form of fat, basically.
Right. Okay.
I guess people are worried about the fact that when they fast, their insulin goes higher than when they're eating.
That's not true. The insulin's not going higher.
Their glucose. Yeah. I'm sorry, their glucose.
Let me explain that, because that's a normal phenomenon, and that's a good sign for us. When we see someone's sugar start going up, we're happy. As an example, I have a patient who's a great guy, and he was on basically a starvation diet, a liquid diet, and lost 44 pounds. When we first started monitoring his sugars, what would happen is every time he exercised, he got hypoglycemic. Why? His insulin was too high. He couldn't get to his fat stores. But after 3 weeks of low carb and keto, guess what? Now his sugars go up with exercise. When I do kickboxing, my sugars go high. When I do Ben's workout, I can't mount that effect. Why? The muscles take up so much sugar, my liver can't kick out enough to oversupply the demand my muscles are putting on, right? So that's why when you do one muscle group at a time, right, your body can keep, you're not getting hypoglycemic, your body can keep up with that. So this is the physiology Dr. Ben is talking about. That's why I was so impressed with his workout, because it changes the physiology, how your body reacts to sugar levels and insulin. So put it this way, doing Ben's workout makes your muscles extremely insulin sensitive. Why? Your glycogen just got depleted, and the first survival benefit is that you have to fill up those glycogens first. So when the next attack comes, you can run away or you can fight. So if you don't do that, what good is it sitting in your liver? It's not good. It's killing you. So put it in your muscles where you need it in the form of glycogen, right? So it's like the way I tell my patients is like a sponge that soaks up the sugar water for your muscles. So if you keep them full of water all the time, you can't soak up any more sugar, right? But if you wring them out, like Ben's saying, now you have a sponge that wants to soak up all that sugar in your bloodstream. And guess what? It has to pull from your fat stores. It forces the issue. Hopefully that makes sense.
Well said. That's better than I've ever said it, Brian. I may take you on as a partner.
All right, let's do it, man.
All right, Jeff.
Pam Devine has a question. Have you seen measurable change in leptin resistance with diet and exercise?
I have. Brian, have you? I've seen leptin numbers drop. In fact, I think for some reason, and I don't know what the lag time is between insulin and leptin, I've found those to be pretty well correlated, but I think there's some kind of a lag time from one to the other. I've seen when leptin numbers drop that people could get over plateaus. I have seen benefit from that, and that's why I kind of measure it, because I'm real curious about, I don't know how much literature there is on that or testing, but I do think that, again, I don't know, chicken and egg, which is which, but they're correlated, insulin resistance, leptin resistance, but I do measure it because I'm curious that the satiety factor might be something. If we can induce more satiety, we would get better results just behaviorally.
Very good.
Listen, you want to add
What is a healthy level of testosterone for a postmenopausal woman? And then we've got a 71-year-old woman. She's saying, is it testosterone important for me at 71?
I think it is. And as far as the levels, the normal levels, aren't they? You guys do more labs than I do, but I think the normal levels are all over the world. I mean, from like 400 to 1100. I mean, and again, for women, it's lower, but the range is so huge that I almost think it's so individual that if you suspect a low testosterone level, especially in a male, that maybe you want to try a little bit of therapy and see if that gets you a result, because they literally are. There's an enormous range that's considered normal.
Should a 71-year-old consider a doctor prescribing testosterone?
Yeah, I think so. I think I've seen it help. Yes, I have. I've seen it help. And again, they come in with, there are some testosterone levels that I have never even imagined. I mean, literally zero. I mean, there's nothing that can be picked up by the test. So I think you certainly, that would certainly not be optimally healthy, and you certainly could benefit by somebody who knows what he's doing or she's doing, supporting that a little bit and boosting that up. Yeah, I agree. I don't know about you guys.
Yeah. So I do think there is benefit for hormone replacement therapy, which includes estrogen, progesterone, and testosterone. And testosterone's often forgotten about with females, but as Dr. Ben was discussing, it is incredibly important for many reasons and functions. The only caveat, I think we have to be pretty careful with how it's prescribed and the quality. It's bioidentical hormones are very popular right now, but we have to remember we don't have randomized control trials and long-term studies for a lot of them versus like this more synthetic hormone replacements that we do have studies on. But the pharmacies vary greatly in their quality of hormones too. So I think testosterone replacement therapy in females, even in your 70s, can be very beneficial, yes, but I think you have to make sure you do your due diligence and kind of scope out the provider and pharmacy who's supplying it.
Yeah, good point.
Yeah. I don't do a huge lab panel generally because all these things get better with the ketogenic or a low carb diet. So we just had a meeting with all of our patients. I don't even check leptin levels. You know what I check? To say, hey, are you hungry? Nope, haven't been hungry. Satiety is what we're looking for. That is the key. Satiety, not being hungry all the time.
Yeah,
you're on a liquid diet, you're hungry all the time, you're grumpy, you hate life. So I know leptin levels are improving just because of the leptin sensitivity is improving just because of the clinical outcome. I don't need to see the number on
I mean, I agree with that to an extent, Brian, but I also think a lot of people are kind of numbers people. And if you can say, well, there's a reason why this might be happening, and if you can show that level dropping, it's an incentive. It's behavioral. Say, listen, there, we're doing good. You're going in the right direction. So I don't disagree with what you're saying. You got to have some horse sense when you see good stuff happening and good behaviors. You can associate that, but I think it's just a manifestation and a reinforcement that you're doing good, keep it up kind of a thing.
So on that subject, White has a question. He says, as his ketones go up, as he feels like he's deeper into ketosis, his appetite goes down to the point where he doesn't feel like eating. What can he do to maintain an appetite?
Hang out with me if he wants.
Yeah. So, is there a correlation between, say, leptin and ketosis, such that appetite gets squelched to the point where he's going to undereat? So, a little insight on this. Dwight's a client of mine, and we're trying to keep him at 73. We're trying to keep him at around 150 pounds. When he's strictly in ketosis, deep into it, he starts to lose weight, starts to lose a little bit of muscle strength because he's just not eating enough.
Thank you. Yeah, so that can be a problem. We do see patients that have wanted to adopt a ketogenic lifestyle for the health benefits and neuroprotection and especially for cognitive function, but they don't want to lose any weight. And once they become fat adapted, as Brian was saying, your appetite does go down. Your body's able to tap into its fat stores and glycogen stores to use for energy. So you do have steady glucose levels. You don't feel that constant hunger that comes from fluctuations in glucose and insulin levels. But I think really what you want to do is you have to, when you are on a ketogenic diet, you have to remember insulin is not all bad. We talk about it in the importance of insulin sensitivity, but insulin also is anti-catabolic. It's often referred to as anabolic to promote growth and muscle growth, but it's really anti-catabolic. It prevents breakdown of muscle. So I think stimulating muscle, like with Dr. Ben's workout, is extremely important too, and making sure that you are getting adequate protein, especially to maintain muscle mass. And if that's in the form of like whey protein shakes, if you feel like you just have no desire to eat any more food, and just scheduling regular meal times. I've definitely had a couple of patients that I've had to say, we're not fasting while we're doing a ketogenic diet. Even if you're not really hungry, you're going to eat at least 2 meals a day to maintain strength, which is extremely important, especially for postmenopausal women too, and as we age, to offset the natural sarcopenic changes or loss of muscle that come.
Okay. Here's what happens. As you get older, your ability to synthesize, to make protein, to make muscle diminishes. This is where, like Dr. Kristen is talking about, you probably want to make sure that you're not just eating once a day, because we don't synthesize the protein as effectively and efficiently. We do need a little more input on a couple of meals at least, or supplement basis, because we're just not as good at synthesizing protein as we get older. And I think the protein is really important, along with the high intensity exercise. And as far as appetite, that I have not run into that too much, but if that it becomes an issue to where you're becoming sarcopenic or losing muscle, which does happen, you have to make sure you're getting protein and maybe even supplementing a couple times a day, because that synthesis rate definitely diminishes. That's why testosterone and growth hormone levels might want to be tested, in my opinion, if we're talking about muscle, because they will definitely help you synthesize protein. Testosterone upregulates the maintenance of broken down protein, so it's anti-adaptopic, it's anti-breakdown, okay? And that's really what testosterone does. It allows you to maintain some of the broken down protein, not turn it over as quickly, whereas women turn over protein much more effectively and efficiently than men. Men hold on to it better. That's why men usually have more muscle mass, but that has to do with a lot of it to do with testosterone levels.
Would that mean that women heal faster than men if they turn over protein faster?
You would think so. If the healing has a protein matrix involved, which most tissues do have, I would think, yeah. And I don't know that specifically. It's something I'm sure you can just Google it and find out. But yeah, well, I always say, women are tougher and they come out of a hard physiological situations better than men. It might be part of that, but I think so. They do turn over protein more efficiently than men at every age. But by the same token, they don't maintain muscle as readily because of that turnover. Okay, so yin and yang again, that men do as far as muscle mass. Testosterone helps you maintain muscle mass by not breaking down. It inhibits autophagy rate. Let's put it that way. Okay.
Mm-hmm.
So I would like to add on to that collagen is very important for tissue repair as well, and it has to do with the amino acid profile. Leucine is an amino acid that's very important for muscle growth and muscle development. When we're talking about tissue repair, you really want to focus on glycine as well. That seems to be the major amino acid, which is a building block of protein. So the type of protein you're getting to, and I definitely believe that animal source protein has the most bioavailable form, and that can be synthesized and utilized by human bodies more than plant-based protein. But really, collagen protein is very important for tissue repair and wound repair and recovery, and it's because of the high glycine content.
Okay, one addition, and you've heard me say this before, studies that have not been published yet indicate that if you take, I think it's a tablespoon, like 20, 25, 30 grams of hydrolyzed collagen or gelatin 20 to 30 minutes before resistance exercise with a little bit of vitamin C, because that's a cofactor, you increase collagen uptake by 500%.
So let's go back to insulin a little bit. Somebody wants to know, is there a home measuring insulin kit? As far as I know, there is not one, but they'd like to know, well, then how often should they get their lab work done to measure insulin?
There's really not a benefit of doing it too frequently. We're usually checking it now at baseline and then halfway through our program, so maybe 6 to 8 weeks, because we're looking for those changes with doing it. It depends what you're doing. If you're doing bench workout, you're going to drop your insulin quicker, right? So there's not a home insulin test. There actually is one, but it's extremely expensive and is probably not beneficial. So, when we order it at our clinic, it costs $12.95 to get an insulin. This is why it's so frustrating for me as a doctor. There's a lot of patients coming to me from big HMO plans. The doctors refuse to check an insulin. Why? They don't know what to do with it. They don't know what it means. Coronary calcium score, they won't get. It costs $100 to do that. To do insulin is $12.95, right? That's what our cost is on that. So that tells us more information than anything. So I think doing it, if you do it too frequently, it is a little bit labile, but over time we see that trend dropping. Our patients, when we follow it, like Ben was saying, sometimes it's nice to use a marker. And so I can say, look, I have a lady where insulin dropped from 85 down to like 12. That is massive. That is in 6 weeks. So that is a huge deal in her longevity, right? She's getting way more insulin sensitive. She's doing bench workout. So there's things like that there's no sense of checking it every 5 days. I mean, if you're on the right path, you're on the right path, and you're doing the right stuff, your insulin's going to drop. There's no way it's not. Or or on the same token, your insulin level can go up. But for people who make very little insulin, this is why I like Ben's workout also. I've had patients who they're not insulin resistant like the rest of us, type 2 diabetics. They just don't make enough insulin. They're on the way to type 1. And when they make their body sensitive to insulin, put on muscle mass, they don't need as much insulin anymore. So they're lowering their sugar and A1C with the same insulin, or maybe the insulin will even go up a little bit. Because when the sugar is better controlled, you can make more insulin. So it is very interesting. So we're looking at, the insulin again in the setting of the A1C and the sugar level, so we know the optimal level. And let me just make one more point on insulin that I wanted to make earlier, because we have a little delay. We step on each other. That's just the way it is. So bodybuilders these days, if you look up a picture of a modern bodybuilder versus the old-time Arnold Schwarzenegger in his prime, these guys have huge bellies, but it's six-pack abs on top of it. You know why?
Right.
They're shooting insulin for the anabolic effect or the anti-catabolic effect to make their muscles bigger. They eat a ton of carbs, and they shove it all into the muscle tissue, right? The glycogen storage makes the muscles look bigger, but they have visceral fat, so their belly will be sticking out like crazy, but they have a six-pack on top of it and all defined muscle. They're not putting muscle out in the periphery. They're shoving it into the liver, basically. So they're putting themselves at major risk of cardiovascular disease and early death.
Yeah,
so it just shows you that.
That was a good point, because insulin is a growth hormone. There is no question about it, and that's the ultimate manifestation of abuse. Yeah, that Brian described.
Dr. Kristen, Jessica has a follow-up question. Any idea how much collagen is in a typical homemade bone broth, and how much would you suggest a day?
So it really depends on how you're making the bone broth, and now there's a lot of bone broth powders and things. What's in a homemade bone broth, I don't know offhand. Most bone broth is somewhere between like 8 and 12 grams per cup. I recommend there are good studies too, not just for the tissue repair with joint health and skin and elasticity. A lot of studies seem to focus on 10 grams a day, and they are showing that they're having beneficial effects. I thought Dr. Ben had an excellent point. You definitely need vitamin C with it for collagen to work properly how it's supposed to. There are some, I think Vital Proteins now has a collagen powder that has vitamin C with it. Or just making sure you're getting vitamin C in your diet or a supplement as well. But collagen, at least 10 grams a day with vitamin C, I think is going to be beneficial for most people.
All right. I know with our client Dwight, we're kind of force feeding him whey and collagen. We have him eating about 2 to 3 times a day. We've got him doing Dr. Ben's workout verbatim, supervised in one-on-one sessions, and we got him stretching. In addition, so he's not just totally sedentary, but he might be someone that we would do possible hormone replacement if he shows up low testosterone. Is that correct?
I say yes. I would check it if you're having problems with that.
Mm-hmm.
The caveat is and making sure, because testosterone and prostate cancer is definitely a significant issue. Not that it causes it, but it will bring it out faster or feed it if you do have it. So that's always a factor. That's why I'm not a huge advocate for the most part, because guess what? I have a lot of obese guys that come to me with testosterone of 100. They leave me with testosterone of 700 through making them, because the estrogen has an anti-testosterone effect. You drop the estrogen that comes from the fat tissue, testosterone goes up naturally. There weren't people with low T 50 years ago. They weren't shooting testosterone 50 years ago.
Jeff, can I ask you what he's doing with the diet and how strict you feel he's being about it? I mean, it sounds like he's doing Dr. Ben's workout pretty strictly because you're monitoring him, but you can't monitor the diet. How confident are you that he's actually sticking to it?
So I've written the menu for him that's within the proper calorie range and the proper protein level for protein synthesis, but his appetite is making him non-compliant. He's saying, "I'm just not hungry. I'm not. I feel like I don't want to eat. Like I get full halfway through the meal." So he doesn't complete the assigned meals, even though we're trying to make them very dense. So,
And this is
his question.
Jeff.
This is a 73-year-old guy, 150 pounds.
You've met him, Ben, I'm sure. Didn't he come down to Coronado last year or so?
Yes.
Yeah.
Well, here's the deal. Here's what I would think. What I would think is liberalize the carbs a little bit, knock yourself out of ketosis and see what happens to the appetite. Because look, ketones are a survival, it's a survival hormone really, because you look at it, when you get really sick, what do you not want to do? Eat. Your body's trying to preserve itself, right? So when, there's people who are dying and they stop eating, and all of a sudden, boom, they get a time of mental clarity. Why? They're running on ketones, right? They remember, oh, pay this bill, go call grandma and tell her to do this. Make sure my life insurance is good. Then they die a week later. Because ketones have a very powerful effect on all these systems, for sure.
Another thought is how does he have weight to lose? Because, if...
No.
Is he...
No, so, Brian, that's a good point, Brian. That's a really good point. Introduce some carbs. They're definitely going to... They should stimulate some appetite, unless you've got him so indoctrinated, not you personally, but he is so indoctrinated about his ketone levels that he doesn't want to let go of that. Brian's absolutely right. Yeah.
He orders his cream from Pennsylvania from this Amish farm, and they also send him milk that has carbs in it. And so he's had a little bit of milk post-workout, and it brought his weight back up, but he stopped it because it brought him down to trace levels of ketosis.
Yeah, right. That's what I was, you got to get his head straight on that. It's obviously, number one, he doesn't want to lose lean tissue. You got to explain that to him. And in his case, you could, blow smoke wherever and just tell him, listen, you're doing so good that we have to actually back down a little bit. You need to have a little bit of carbs, and don't worry about the ketones. The reason they're not showing up now is because you're using them as fuel. Tell them, half of a story or so. I mean, you got to make this guy do this.
He's listening right now, Doc. He's listening to you right now.
That's true.
So listen.
That's absolutely true, though. Yeah, that's absolutely true, Ben. For sure.
Yeah.
Very good.
He's so lean. He's using his ketones as fuel. Therefore, they are going to go down in his bloodstream. Does that make sense?
Yeah.
Well, Ben, I did Ben's workout, and my ketones dropped by 80% doing Ben's workout. Because I was fat adapted, I didn't have any other fuel. My body burned the ketones. So when I say, oh no, this isn't good, my ketones drop. It's not we can't chase the ketones. If you're making some ketones, you're good. And you don't have to be in ketosis consistently all the time, especially if there's a contraindication to that. The rest of us, yes, it's good to be in ketosis because we're trying to burn our body fat. But if you're trying to maintain lean muscle mass, you don't want to lose that. Mm-hmm. And if insulin is anabolic to some degree, you want to spike it a little bit if you're very insulin sensitive.
Jeff, I'm in an age group, and my ketones are not that high, constantly. They're just not.
Yeah. So hey, Dwight, it looks like we're doing it right, Dwight, and we don't have to chase the ketones. Right? Very good.
We have menopausal patients. I think we're dealing with two things, right? What we're finding is the people who worry the most about their weight, that weigh themselves 3 times a day and get stressed out if they don't lose a pound. I think they're getting a cortisol spike because of the stress of looking at the dumb scale. What do you think we do with that? Obviously, getting people who are plateaued, I think my biggest recommendation is to do your exercise correctly and watch what happens. That's going to break through that plateau. But, what do you think about this cortisol stress response that we're seeing? My people who don't care about their weight so much is what I'm saying. They'll drop weight like crazy, but the ones who are really hyper vigilant really seem to struggle.
Double-edged sword. The ones that are doing well don't care about it as much as the ones that aren't doing well. So the ones that aren't doing well are going to have more stress. So it's a vicious cycle. But I think one of the things we can express is that when you do this exercise, it is very likely that you're going to increase bone density and muscle mass. So on the scale, it's going to be weight. So I think body composition, a way to assess body composition rather than weight, would be helpful.
And that's what we're doing. And you know what's funny is we're seeing patients who are losing weight slowly, but their visceral fat is dropping by 2 or 3 liters. The visceral bad fat is dropping like crazy, but they're not seeing it on the scale. And it may be that they're replacing they're adding muscle mass on. So we're seeing them getting metabolically healthier, no question about it.
Yep.
Blood pressure getting better, insulin dropping, all those things, but the scale is not as impressive as these other
I
markers.
see that.
We have.
I've been seeing that for 45 years. I've been seeing that. That's exactly what happens. I mean, they put on muscle mass. I mean, you can visibly see. I have a couple of clients that are, 3 weeks into the program. You can see that they've put on muscle mass. There's two ways you can see. One, they've lost body fat, so the muscle's more apparent, but they've put on muscle mass. There is no question. And the weight loss still happens, but it happens at a net rate slower than, just losing weight, because they're gaining muscle weight.
Just to chime in there too with that, I think with postmenopausal women, which is the majority of my patients, I'm more concerned making sure they maintain muscle mass as they age, because that's muscle's the organ of longevity, right? You don't want them to be playing with their grandkids and fall and break a hip and it goes downhill. So really focusing on the body composition opposed to the number on the scale is really key for overall health, not just what the scale's reflecting.
Absolutely. Yeah.
Ben sent me the studies on that. I've seen the studies. He's correct. If you're in the top third of muscle mass, you decrease the risk of cancer by 40 to 80%, Ben, and the other studies showed the chance of living to 100 is like 40 to 60% higher.
Yeah. If you're in the top third for your age and gender and muscle strength, singularly, that variable, the 35% less likely, 35% less likely to die of cancer, 40% more likely to live to be 100. That singular variable is the most highly correlative factor to longevity, muscle strength, and obviously muscle mass is associated directly to that.
Look, I tell my patients, because I know it happened to me, 3 or 4 weeks into low carb diet, my sugars in the morning started going up, eating low carb or keto, and I'm in major ketosis. Your body is freeing up energy for you to use, so it is expected generally that in the morning you're going to have a higher sugar than you used to. What I'm finding now is my patients, after they eat a low carb or a ketogenic diet, after they eat, they're dropping their sugars after that. Fasting, they're rising up, like it'll look like this in the morning, it'll be high and then start, and then all of a sudden they eat and their sugars drop. And then I know, hey, they're fat adapted and they're eating low carb. The big take home for that is the American Diabetes Association says, okay, when you eat your high carb meal, shoot insulin to get rid of that sugar. And so when I ask the dietitians, say, okay, how much insulin should I give this person when they're dropping their sugars every time they eat? Because they're eating the right food. The answer is no, they don't need any insulin with that food, unless obviously they're type 1 diabetic. So this is what we're learning. Don't worry about the sugars going up. I think what you want to do is look at the A1C and the 3-month sugar average. Because I've seen some crazy things where people work out hard. I have a 100-pounder female physician from Texas who consulted me because her sugars would routinely go to the 250 range after working out, because she would work out for 2 hours a day and she was extremely lean and keto. So I said, liberalize your carbs, do Ben's workout for a week, and guess what? Sugars normalized. Because she wasn't getting that cortisol stress response because her body was panicking because she needed energy.
Right,
she didn't have any energy to give her body.
Yeah. Very typical, Brian.
Yeah, so don't worry about the sugars. I mean, look at the overall, the A1C should be dropping the time.
Yeah, my sugar comes down after I eat. Every time, just about every time, seriously.
Human growth hormone, do you see that improving with putting on muscle mass? Is it the opposite? Do we see HGH improving our release of
IGF-1, which is how you measure it, will improve with increasing muscle mass and high intensity exercise? Yes. To what extent? The literature is basically equivocal. Okay, so but yeah, I see the effects, or what appear to be effects and benefits from high intensity exercise in growing muscle. And a couple of people I've done just asked them to go get IGF-1, and we got a little bit of a bump. Yeah.
Someone said she just joined now. Where can I find Dr. Ben's workout?
Well, yeah, tell them.
Low Carb USA on YouTube has about, how many did we see the other day? Like 16 videos or something in the high intensity, slow resistance training or something. I'm going to add
she can
Dr. Ben
contact
into
me.
that actual category title as well. But yeah, I mean, there's tons of videos on that. And then there's your book. There's all sorts of things.
Yeah, and you can contact me if you need direction. 15 minutes to fitness, yeah. But yeah, no, contact me if you need help with it, and I can set you in the right direction.
One lady here is asking if Kristen has suggestions for if providers are prescribing bioidentical hormones.
Right. So no, that is a good question. Offhand, in San Diego, I have not been here long enough to get familiar with providers that are prescribing them. If you're out of state, I know a few people. Teresa Mealy is a good resource there too. But personally, I have to be honest, I'm not a big advocate for prescribing hormones in most situations until we've already optimized the diet and lifestyle. The exception is definitely post-menopausal women. If their testosterone levels are at 0, like Dr. Ben was saying, yeah, there can be an argument for it. But we see so many improvements in hormonal levels across the board with a low-carb diet and high-intensity training that women tend to feel much better. And I think the idea of getting hormone replacements gives this false notion that you're going to feel better, everything's going to be better if you can just get some hormones back in you. And we're finding that really diet and lifestyle are going to make you feel just as good, even if your hormone levels have changed post-menopausal. But to answer your question, unfortunately, I don't know anyone in the San Diego area right now who's I feel comfortable enough to recommend for hormone replacement.
Okay. Jessica Inwood just had a statement. She said, I gained weight, she's talking to Dr. Ben, I gained weight during your workout, but my fat mass has decreased. It's been awesome. Muscle is the life force. Oh, that's a message for Dr. Ben.
And that one from who?
Jessica Inwood.
Hi, Jessica, your check is in the mail. Thank you.
It's another question coming up about if you eat too much protein, it'll cause gluconeogenesis, and the reason for glucose going up. That's a rabbit hole.
Yeah, it's an urban legend kind of. I mean, and you can. Ben Bigman gives a pretty good talk about this. Brian, I know you're familiar with it. The response to protein has almost everything to do with insulin levels. Okay, if your insulin levels are really high, you'll probably instigate gluconeogenesis. If they're low, you probably won't. Isn't that the case, Brian?
Absolutely, I 100% agree. Yeah, I think that's what we're finding. If you have a poorly controlled diabetic and you give them protein, they're going to spike their sugars. But we have to look at the whole point. They're not going to spike the sugars as much as if they eat a donut, I'll tell you that. So we have to look at the picture and what we're trying to accomplish. Because it's hard to really tell someone we're going to put you on it. And what we do sometimes, put them on a high-fat diet to start with. And this is not a high-fat for the next 20 years. It's for a month to get fatted out. Because once your body starts using fat, guess what? You drop your insulin significantly. And this is across the board. So once you drop your insulin levels down, now you eat that same protein, it doesn't spike your sugars anymore. Ben Bigman's shown this. Clinical experience shows this. It's just the way it is. And so people who are listening who are interested in Ben's workout, Jeff Cotterman does it at Tri System. There's Leo's Fitness Lab has the machine that duplicates Ben's workout. So there's places we can do it in San Diego, and for my patients, I highly recommend both because whichever one's more convenient. Obviously, Jeff's hands-on and he's there with you, but doing this will give you the most bang for your buck if you get into nutrition right. This is the key. When I saw Ben, I laughed at Ben when I first heard about him, and then I started looking at science and I was blown away. But the people who are doing both definitely have better outcomes. There's no doubt about it.
Kristen, I think for you, is there a contraindication to postmenopausal women taking testosterone related to an increase in blood clotting if she's taking medication that increase blood clotting. Okay.
Yeah, so that is a big risk with any hormone replacement therapy. You do have an increased risk of blood clots, especially with estrogen too. And as Brian was referring to, men with testosterone replacement therapy, we don't talk about the side effects often, but it can promote certain cancer. Any type of hormone replacement therapy can definitely increase your risk for blood clotting. It can increase your risk for certain cancer growth, not all the time, but if it's there and it's hormone sensitive cancer, it definitely can. So all of these things need to be taken into consideration. And same thing, even if it isn't a postmenopausal woman, women on birth control pills that contain estrogen are at an increased risk for blood clots, especially after the age of 35, and an even bigger risk with obesity. So I think all of these things do have to be taken into consideration, and that's why it's so important to have a provider who understands these risks and can monitor your levels and make sure the benefits outweigh the risk before starting something.
Yeah, good advice.
Okay. Any others?
That's it, right, Tammy? Yeah, that's all we got here, kid.
Okay, that's cool, man. Thank you very much to everyone for joining in. It's kind of a training ground for us, so sorry for the glitches and stuff. But there's features from this whole live stream system that I didn't even dare to try during the event because I was scared things were going to blow up. But I'm trying other little things here and there to try and hopefully down the road make sure when we have a major event that it runs a lot smoother and we have less problems. So thanks for putting up with our hassles, and we look forward to next month. We'll try and make it a good one then as well. Right, guys. Thanks. Bye.
Hey.